Good afternoon, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire, and joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Hey, Doc. And we're also joined by Lieutenant Jerry Martin.
Hey, Chief. Thanks for having me.
Thanks for coming. I really appreciate you coming out and talking with a very important case and a very important topic. This call came in as a cardiac arrest for a pediatric patient for a 2-year-old. But due to your good work and your diligence and your treatment, we found that this likely was an overdose. So unfortunately, it's very prevalent in our system. Today we'll talk about it a little bit with Doc. So you guys handled this call perfectly, and I kind of want to pick your brain on it. So Rescue 14, Engine 14, I know 7-8 was assigned with it as well because it was a code. Came in as a 2-year-old female. A lot of things going through your mind, I'm sure, every time we hear that dispatch. Tell us what you're thinking when you're on your way to that call.
So the dispatch came about 1 a.m., so we all woke up kind of out of that first REM sleep after going to bed and, trying to wake up, get your brain functioning, get in the thought process of what we're going to do. Initially, it was just 9 echo. That's all we had. At this point in time, I had worked at 14s for a few cycles, so I was comfortable with the crew. We had worked very well together, so I just thought business as usual. A 9 echo, okay, start going through my thought process for that. Get to the truck, open my MDT, and I see we're going to County's district. So automatically I'm starting to think, okay, we have an extended ETA. It's going to play into certain factors when we show up. And there was no info. I believe the call came in from County's side, so I didn't have any info in the info line. So we get going code 3, and I ask alarm if they have any additional information, and that's when they relayed over the radio. We're responding to a 2-year-old female cardiac arrest. And so as EMS providers, we know any sort of critical pediatric, it just heightens the level of stress for everybody. So whenever we're going to a pediatric call, I like to pull up my protocols, go to my EMS guidelines app on my MDT, and pull up the protocols. So we pulled up the cardiac arrest for peds on that. And then I also like to pull up the formulary and get my pediatric dosing chart out, just so I have it to reference. I'll be the first to admit I'm not the best at, from memory, getting my weight-based dosages for our pediatrics. So I like to have it open, ready to go for if I need it. So yeah, on the way to the call, just kind of going over all that with my driver. Hey, when we show up, this is what we're going for. I think we even referenced the new placement for the IOs for pediatrics. Okay. We pulled it up and just talked about it for a quick second. We had a little ways to go, so we talked about a lot on the way to the call, just brainstorming. So,
and it's a lot of good information in there. One of the things that's a frustration, I know, for some of the field crews, and we unfortunately can't find a workaround, is with the new mock alerting system. It tells you it's a 9 echo, and then it won't elicit like an age of that patient. So I know when we hear that, it's very different for a 90-year-old, to a 9-month-old. Our thought processes are different. Alarm Room's done a fantastic job is getting as many notes into that MDT as we can, but you add that additional caveat of that call coming from County, who doesn't operate exactly the same as our Alarm Room dispatch, which is uniformed and makes a huge difference. So a lot of curveballs there, but I'm glad that you guys really took that opportunity to talk through a lot of those things, because all of that is huge before arriving on the call. So great job. All right, so you guys get there now. Tell us what you see and what you do.
All right, so when we're arriving, a lot of the critical pediatric calls I've been on, you're going to have frantic family members and bystanders. And a lot of times you have no idea where they come from, but there's all of a sudden a crowd. So I was hoping PD was there. They weren't there upon arrival, but as we pull onto the street, I don't know who these people were, but there was people sprinting down the sidewalk heading to the same house. I don't know if they're concerned citizens, bystanders, family. I don't know who they were. So I see people sprinting to the house, and I'm like, oh man, we're going to be in for a little bit of trouble when we show up. So we get out, get our bags. We're approaching the house. I can see the patient, 2-year-old female. She's lying in kind of the front walkway with who I'm assuming was the father attempting CPR. So show up, and we pick the patient up. I pick the patient up and move her to the middle of the living room, kind of give us some space to work, open our bags up, and start assessing the patient. Of course, like I said, as we're assessing the patient, the dad's crawling over my back, literally on top of me. And I tried to mic up and ask for PD, and luckily they showed up right then and there. And then they sat him on the couch a little bit away, and we first laid her on the ground. She was just wearing a diaper. She didn't have any clothes, just the diaper. We go to check for a pulse. As I'm putting my fingers on her carotid and brachial, she takes an agonal kind of gasp respiration. So I'm like, okay, so it's not a complete cardiac arrest just yet. Let's make sure we have a pulse. I feel a weak carotid pulse. So I was like, okay, guys, she has a pulse. Let's get her hooked up to the monitor. And when she took that gasp for like a split second, I could feel all of us, because we were ready to work a code. So we had in our mind, this is what we're doing. And then as we found pulses and she had that respiration, for a split second, we kind of froze and we're like, so what's causing this? What are we going to do now? And a lot of times I've found when I show up to a very critical call and just kind of don't know where to start, I'll in my head just kind of just say ABCs, just ABCs, ABCs. If we can just start somewhere and start fixing the life threats that we can fix, usually it'll lead us to the algorithm that we should be following. Let's just start fixing something. And so with our cardiac arrests in peds, a lot of times there's a respiratory component. So my thinking was, let's just get really aggressive with the airway, make sure there's nothing including the airway, start bagging for the patient. Obviously her respirations, we're oxygenating her. She was pale and cyanotic around the lips. So we started getting the BVM together, the two drivers getting the BVM, hooking it up to oxygen. The pipemen were putting the patient, the pads on, the pediatric SAT probe on her. And my driver was looking for IV access, and I started to get my laryngoscope out just so I can visualize the airway, make sure there's nothing occluding it. And as there's like a million things happening, I'm kind of throwing out questions to bystanders just to see if we can get some sort of info. So there was no significant medical history, no history of seizures, no seizure activity before the incident happened. I asked, is there anything that she could be choking on? I got someone threw out, she was eating Fritos before you showed up. And then in the back of my mind, I'm like, it's 1 o'clock in the morning. Why is this toddler in a diaper eating Fritos? But we just went with it, got aggressive with the airway. I was expecting to open the airway and see a Frito, get my McGill's, pull it out, good to go. So coordinating with the person bagging, get the laryngoscope, open up the airway, and nothing. Airway's completely clear of obstructions. It's patent. And in that split second, I was kind of taken back. I was like, okay, so it's not airway. What is it? What are we going to do now? And luckily, about a month prior, I was talking to my buddies on Rescue 5, Lieutenant Bergman and Matt, and they had discussed the call with me, unconscious, unresponsive pediatric. Patient was seizing due to hypoxia, so they fixed the seizure, and then they pushed Narcan and had success on that call. So in the back of my mind, I'm like, okay, let's go that route. Let's try it. I mean, I'm already at the head, visualize the airway, take the laryngoscope blade out, open the patient's eyes, and I just used the light from the laryngoscope just to check pupils, and sure thing, they were pinpoint, unreactive. And I relayed that to the crew. I was like, hey guys, we have pinpoint pupils. We're gonna start going that route, keep bagging, let's get the Narcan ready, and I'll get my MDT and I reference the dosage for that. So we called the patient 20 pounds, and with the pediatric dosing chart, we were going the intranasal route, and it was about 1 milligram is where she fell in that range. So we gave half a cc per nair. And then after giving that, her oxygen saturations were starting to rise from the bagging. She started to get pink. The cyanosis kind of seemed to be diminishing. And at that point, we all decided, okay, we've kind of stabilized our life threats. Let's get going to definitive care. Let's get her going. And it was about 90 seconds. They were putting her onto the gurney, and she. I heard crying. I was still inside getting my MDT and some info, and then I heard her start crying and everybody consoling her. And it was a big sigh of relief for everybody, for sure, just to know that our interventions were having the desired effect. And so that's kind of how it went.
So, and that's a fantastic way to describe it. It was perfect. I think to paint the picture initially, as far as vital signs, it looks like we had a respiratory rate. Maybe we counted about 6. I think early capno, when you first got that on, was 15. We didn't really have much else, but as you guys started to work and broaden everything out, we had vitals that when you repeated them, we had a heart rate of around 92. O2 sats came up to 86 with that BVM. We were helping her breathe about 12 times a minute. Capnography came up to 41. Her temperature was good, 95.7, a little bit low, but blood sugar was good. So you literally covered every base with this patient, from the sugar to the airway to what ultimately ended up being a suspected overdose, and ultimately, saved this baby's life. It was fantastic. So you kept in mind the fact that, like, for any child, if they're minimally responsive, to consider Narcan. It never hurts. And it can always help, right? Although you can't always rely on pupils, you did a good job of getting your laryngoscope in there, taking a look with the light. What else, Doc, cutting over to you, can we be looking for in these cases with these kiddos?
Yeah. So I just want to say great job. You did a couple of brilliant things early on. Taking the child inside rather than taking the child and running to the ambulance, taking her inside where you had room to work and then think. Realizing she was peri-arrest with a really soft, weak carotid, and then bringing it back to the basics, just the ABCs. And then that got you to where you needed to be. Thinking about the Narcan, I'm so glad you guys had that talk earlier, so it was in your head. And then now that we're talking about this, more people will have heard the story and start thinking about it too. Other things with unconscious, unresponsive kids, peri-arrest, respiratory is always number one. Unfortunately, lately too, with the fentanyl epidemic, these toddlers especially are getting it. They put everything in their mouth, right? So it can be a contaminated object on the table. It could be the pills now, the blue fentanyl pills that look like candy. So keeping that high on the list, but also non-accidental trauma, shaken babies, maybe a blow to the head, any recent trauma, something like that, where there's bleeding in the brain. Gotcha. Can also cause a confused mental status. And a lot of times that'll come in with alteration, vomiting, or seizures. Doesn't sound like that was the case here.
No, luckily our patient was already kind of exposed when we got there, so the initial assessment pretty much covered that. But yeah, it's definitely good to expose any pediatric patient to kind of get a broader picture of what's going on.
Yeah.
We talked about the Fritos and the other stuff that some of the family was mentioning in the back. At any point during this, even after the treatment was effective, did anybody elicit that she may have gotten into something?
Yeah, so a part of that call, PD got the father, kind of sat him down on the couch. He was in the room, so I was questioning him, and they were standing right next to him. But after I saw the pupils, I asked him, I said, is there any chance that the patient got a hold of any narcotics in the house? And instead of a immediate no, you could see him kind of look off into space, and he was kind of trying to think, if what the answer would be. And that kind of told me all I needed to know. He never actually answered me, but at that point, with our findings, the respiratory depression, pinpoint pupils, and then his reluctancy to answer the question right away, I kind of assumed the answer from that. So
Unreal. And we've talked about this before in other cases, Doc. This is becoming more and more prevalent where we're seeing it almost once a month, that we're seeing it in our chart review in our system, but at the hospitals, because some of these patients are brought in POV or other mechanisms, that they're up to one a week that the hospital, UNM at least, is seeing that they're getting into substances. So it is pretty prevalent.
It is. You know, it's not uncommon that 2-year-olds have come in with an ingestion before, right? Like that has always been a thing. It's just now that these dangerous, deadly drugs are more prevalent in the community, the kids are getting into them as well. And sometimes it's hard to tell. They could have, you know, if she hadn't responded to Narcan, it doesn't mean she didn't get into anything. And most overdoses are, the right recipe is just manage the ABCs. If they're not breathing, breathe for them. Keep an eye on that circulation. The other great thing that you did, check in the sugar. And being aware of a potential seizure, because some other overdoses can lead to seizures. But it sounds like you covered all your bases and we're ready for everything. And thankfully the Narcan did the trick.
Yeah.
Any other takeaways that you have for other officers that you want to share, or encounter a call like this?
I just think trying to keep the scene as calm as possible. Just being very vocal. Like I said, I could feel all of us kind of freeze up for a split second. So just being vocal, talking out loud, I kind of like to do that. I'm a big fan of, talking on scene. Like, hey, guys, even if I'm just thinking out loud, hey, we're going to be managing airway. Let's focus on that. That's our main important goal. All right, we're going to run this as an overdose. This is what's going on, so everybody can kind of start preparing for something like that. And then just I'm a big fan of that pediatric dosing chart. Just have it available so you're not having to, mess with anything on scene. But the 14's crew, we did really good and worked well together. And we made the best of that situation and got the patient to definitive care in better shape than we found her. So, I mean, that's kind of best we can do.
Absolutely. And you made mention of the fact that you got down this line of thinking by talking to, friends and colleagues that you have at another rescue. And like that hits the nail on the head of why we want to do these is because that, now other people will see it and they'll start thinking that same way. So that's the whole goal of these case studies. So I appreciate you bringing that up because it's exactly what we're trying to recreate here. And then just lastly, on a personal note, we've had 2 opportunities now to sit across from you, like in an official capacity. One was your credentialing, and then one was from here today. And this was even more impressive than your credentialing session, and that was super impressive. So I'm excited to see where you take this. I appreciate you coming out to talk to us, and you and your crew keep up the fantastic work.
Thank you. Thank you very much.
Awesome.
Good job,
Thanks for having me.
All right, and that's all the time we have for today. If you have a case study you want to share, reach out to us via SharePoint under the EMS tab, or you can reach out to your 7-8. And until then, we'll see you next time. Thank you. Thank you both.